My name is Dr. Jeffrey Su from the UCLA Department of Head and Neck Surgery in Los Angeles, California, in the United States. I'll be discussing in this section fibro-osseous lesions of the paranasal sinuses. I'd like to give my appreciation and thanks to Dr. David Gudis, Dr. Jivian Lee, and Dr. David Kennedy for inviting me to speak on this topic. I have no disclosures. The primary goals of this talk are to discuss the prevalence, histopathologic features, radiographic findings, and the surgical management of the most common benign fibro-osseous lesions we see in clinical practice. We will end with some surgical considerations specific to the frontal sinus and some management controversies. I hope you will find this presentation useful to your patients and to your practices. Fibro-osseous lesions represent a heterogeneous group of rare and benign lesions with similar clinical, radiological, and histopathological features. They are characterized by a progressive and variable replacement of healthy bone by fibrous connective tissue. The World Health Organization reclassified a number of these tumors into two main categories in 2017. The first being benign maxillofacial bone and cartilage tumors, which includes the osteoma, chondroma, chondromyxoid fibroma, osteoblastoma, and desmoplastic fibroma. In another category, the fibro-osseous and osteochondromatous lesions, which includes the ossifying fibroma, fibrous dysplasia, cemento-osseous dysplasia, and osteochondromas. This presentation will focus on the osteoma, the ossifying fibroma, and the fibrous dysplasia, which are by far the most common lesions we see in rhinology practice. Fibro-osseous lesions can be found throughout the head and neck, such as the cranial vault, the mandible, and the paranasal sinuses. Histological diagnosis of these lesions can be challenging, and biopsy is often difficult to obtain before surgery. As they are found in a number of locations in the sinuses, they can present with a wide range of symptoms, but most often they are found incidentally. The first of the fibro-osseous lesions to be discussed is the osteoma. Osteomas are slow-growing benign tumors with an estimated prevalence of 1 to 3% in the paranasal sinuses. The etiology of these lesions is unclear, but there might be embryological, traumatic, or infectious origins in some situations. The majority of these osteomas are thought to originate in the frontal sinus, with one study noting an incidence of 75% in the frontal sinus, 20% in the ethmoid sinus, with a small percentage of these in the maxillary and sphenoid sinuses. In another study, the most common location for the osteoma was not in the frontal sinus, but rather in the ethmoid sinus with an incidence of 53%. This group also found that the left side had a higher prevalence of tumors compared to the right, but this did not reach statistical significance. Two large studies evaluated the incidence of osteomas using CT scan imaging. The first, a survey of 1,500 coronal CT scans, found 46 osteomas for a rate of 3%. A second study of 1,889 adults, 57 were found to have osteomas, also for a rate of 3%. The age of discovery of these tumors is usually in adulthood, with a male to female ratio of 1.3 to 1.7 to 1. Symptoms are generally related to osteoma size and location, with the most frequent symptoms, when symptoms are present, being headaches and facial pain. Other symptoms are related to chronic sinus infections, mucocele formation, cosmetic deformities, or nerve compression, most commonly involving the optic nerve or trigeminal nerve. CT scans are the gold standard to diagnose osteomas and represent the most important imaging modality. Generally, they are found on CT to be dense, homogeneous, well-circumscribed bony masses that do not enhance with contrast. MRI scans are generally not required for diagnosis, but can be useful to better understand tumors that extend into the orbit or through the skull base. Osteomas are usually white or tan, round or oval shaped, with well-circumscribed borders. They're usually attached via a broad base for larger tumors and narrow bases for smaller tumors. Histology can vary based on osteoma type, but generally they are made up of compact lamellar bone. Understanding the growth rate of osteomas can be important when discussing surveillance schedules and need for surgery to our patients. There are 2 studies that have evaluated changes in size of osteomas in non-surgical cases. Bayuklu published a study in the White Journal in 2011 on this topic and found that the mean growth of osteomas was 0.79 millimeters in the anterior posterior direction and 0.99 millimeters per year in the medial lateral direction. The authors reported no difference in growth rate based on tumor location. Also important to note was that 49% of the osteomas in the study had no growth during the study period of 12 to 124 months. In another smaller study of 23 osteomas, 13 grew during the study period for a rate of 1.61 millimeters per year and a range of 0.44 to 6 millimeters per year. First described in 1951, Gardner syndrome is an autosomal dominant disease resulting from a mutation in APC, a tumor-suppressing gene found on chromosome 5q21. There is an incidence of 1 in 8,000 births with no sex predominance. Gardner syndrome is characterized by a triad of intestinal polyposis, multiple sinus osteomas, and cutaneous and soft tissue tumors. Colon polyps generally develop in the first decade of life, and there is a 100% risk of malignant transformation if the colon polyps are not addressed early. One of my patients with Gardner syndrome presented with chronic sinusitis and a large number of osteomas in the frontal maxillary and ethmoid sinuses. This CT scan image is remarkable as it demonstrates not 1, 2, 3, but 4 osteomas in a single axial cut. After these tumors were removed successfully and the sinus disease treated, he later presented years later with an osteoma in the mandible and the forehead, which required additional surgery. So long-term surveillance is critical in these patients. Dr. Alexander Chu published one of the first osteoma grading systems for frontal sinus tumors in 2005. There are 4 grades that have strong implications for our ability to treat these tumors endoscopically. Grade 1 and grade 2 represent tumors that are medial to the lemma propria, with grade 3 tumors extending lateral to the orbital wall. Grade 4 tumors are unique as they completely fill the frontal sinus. Here's an example of a grade 1 osteoma in the Chu classification system. It shows a tumor medial to the lemma propria occupying less than 75% of the frontal recess on the axial cut. This is a grade 2 osteoma with the location being medial to the orbital wall as well, however with 75% or more of the frontal recess occupied by the tumor. Grade 3 tumors lie in some part lateral to the lemma propria, as seen on the coronal image on the left. And this is an example of a grade 4 tumor, which are generally the most challenging to remove endoscopically and can require open approaches for tumor removal in some situations. A more recent updated grading system published by a group in Athens, Greece in 2020 also had 4 grades. Grade 1 represents any tumor medial to the orbital wall with a site of attachment near the frontal recess. Grade 2 tumors extend lateral to the lemma propria in a virtual sagittal plane. Grade 3 tumors fill the entire frontal sinus. Grade 4 tumors are unique as they describe certain situations which can make tumor removal endoscopically nearly impossible, including tumors with intracranial extension, tumors that extend anteriorly through the anterior table of the frontal sinus into the forehead, or osteomas arising from the orbital roof, or certain anatomic features such as a narrow AP distance of the frontal recess or far lateral tumor extension. The next fibro-osseous lesion to be discussed is fibrous dysplasia. Fibrous dysplasia was first described by Lichtenstein in 1938. It is a benign idiopathic skeletal disorder characterized by replacement and expansion of medullary bone by disorganized fibro-osseous tissue. Fibrous dysplasia is caused by a missense mutation on the chromosome 20q13. The condition most commonly affects the long bones of the arms, legs, pelvis, and ribs, but is not uncommon in the head and neck. It is a chronic and slowly progressive condition due to excess osteoclastic activity with increased bone resorption. Fibrous dysplasia most commonly presents in adolescence as an asymptomatic, painless swelling. When symptoms are present, pain and ocular symptoms are the next most common. Ocular symptoms include displacement of the globe, exophthalmos, hypertelorism, and diplopia. Diplopia may be secondary to nerve involvement or due to mechanical interference of the extraocular muscles. Malignant transformation is rare and is usually associated with radiation therapy, which was historically considered a treatment option for fibrous dysplasia. Now, radiation therapy is not recommended due to the known risk of sarcoma formation. One study from the Mayo Clinic looked at 1,122 cases of fibrous dysplasia and found 28 cases of sarcoma. The majority were osteosarcoma, followed by fibrosarcoma, chondrosarcoma, and a single case of malignant fibrohistiocytoma. They noted that 46% of patients that developed sarcomas had prior radiation therapy. There are three types of fibrous dysplasia. The first and most common is monostotic, and usually it represents a single lesion found in the ribs, proximal femur, tibia, and calvarium. Polyostotic represents 20 to 30% of cases and is seen demonstrating multiple sites of fibrous dysplasia and is usually unilateral. McCune-Albright syndrome is a rare congenital disorder caused by sporadic gene mutations and usually affects females and is associated with precocious puberty, endocrine abnormalities, and cafe au lait spots on the skin. Radiographic characteristics of fibrous dysplasia include a ground glass appearance, which is generally seen on CT scan and can be highly suggestive of the fibrous dysplasia diagnosis. When this appearance is present in an asymptomatic patient, histologic confirmation is not required, and serial CT scans are sufficient for follow-up. Histologically, fibrous dysplasia is usually characterized by irregularly shaped bony trabeculi. The fibrous stroma contains bland-appearing spindle cells. In the high-powered magnification insert, immature woven bone is seen lacking a rim of osteoblasts. Due to the high rate of recurrence, surgery is generally not performed in the absence of symptoms. When needed, surgery is often utilized for disfiguring fibrous dysplasia. Surgery is also considered to alleviate compression causing a neurologic deficit such as vision loss. And while fibrous dysplasia is commonly asymptomatic, it can cause severe bone pain in up to half of patients. Studies have demonstrated that the pain can be improved with and managed by intravenous bisphosphonates. However, oral bisphosphonates have not been demonstrated to have significant improvement in pain in these patients. The last fibro-osseous lesion to be discussed is the ossifying fibroma. Ossifying fibromas are rare benign lesions that are usually locally aggressive. They most commonly occur in the mandible or the maxilla, but they can also occur in the orbit, the sinuses, and the skull base. The radiographic appearance can vary greatly based on the maturity of the lesion from radiolucent to radioopaque. Pete Mannis performed a systematic review and found 55 cases of ossifying fibroma in the paranasal sinuses. The typical age of presentation was 29.9 years, with a range of 70 to 75 years. The male to female ratio was 1 to 1.04. Facial swelling is the most common presenting symptom, and the lesions are most commonly found in the ethmoid and maxillary sinuses. Radiographic findings were heterogeneous. However, CT usually demonstrated eggshell-thin rims of bone surrounded by a lytic area. MRI scans generally demonstrate low to intermediate signal intensity on T1 imaging and variable intensity on T2 imaging. The outer layer of the lesions usually enhances with contrast. Unlike the other lesions, upon diagnosis, surgery is generally recommended. The goal of surgery is usually complete surgical removal, as the growth rate can be unpredictable and these tumors can be locally aggressive. When discussing the role of surgery for fibro-osseous lesions, each specific lesion can have its own treatment recommendations. For example, osteomas are usually removed when they cause post-obstructive sinusitis. Fibrous dysplasia, on the other hand, is considered operable with select indications, for example, when causing cosmetic deformity, orbital changes, or with nerve compression. Ossifying fibromas are generally recommended to have surgery with complete resection in mind. When surgery is required, like other benign tumors, choosing the best approach can make a difference between complete removal with minimal morbidity and complications or incomplete surgery. When performing any tumor surgery in the sinuses, it is generally recommended that the surgeon is comfortable with both open and endoscopic approaches for the best outcome. Treatment of fibro-osseous lesions is no different. Here are two surgical pictures of patients with frontal sinus osteomas. The first had a successful outcome via a draft 3, and the second required an osteoplastic flap due to 100% obstruction of the frontal sinus. The greatest controversies in management and surgical approach lies in tumors involving the frontal sinus. In other paranasal sinus locations, endoscopic surgery has significant advantages over the lateral rhinotomy, midface degloving, and the Caldwell Luck. I do not see any additional benefit for open approaches to the sinuses, but certainly minimally invasive transorbital approaches can be utilized with great success when needed. This figure outlines the pros and cons of the osteoplastic flap compared to endoscopic approaches. I've highlighted what I feel are the most important factors to me, but all of the points should be taken into consideration to some extent. For example, when considering the osteoplastic flap, I feel that the biggest advantage by far is the unparalleled access it provides to all parts of the frontal sinus. Whereas with endoscopic surgery, the main goal is to reduce morbidity related to pain, scars, and forehead paresthesia. In regards to disadvantages, there's a risk of intracranial injury and CSF leak when performing the osteoplastic flap. This complication can be reduced by using navigation as opposed to the traditional 6-foot Caldwell films of the past when entering the frontal sinus. For endoscopic surgery, certainly the endoscopic drills are much slower than the standard drills, and the integrated sections often require cleaning and removal of bone. In many situations, surgery can be significantly faster when open approaches are utilized. One of the biggest controversies in the management of benign fibro-osseous lesions is the management of asymptomatic cases. There is very little controversy in fibro-osseous lesions when patients have symptoms. These patients generally require surgery to improve their quality of life. However, for asymptomatic patients with fibro-osseous lesions, regular surveillance is generally recommended with serial CT scans on a once-a-year basis. But is there a role in elective, non-urgent surgery in these patients? As they become more seasoned, with more years of experience, I've seen patients that were recommended to continue surveillance only to represent with lesions that were no longer endoscopically resectable. Now I at least consider that there might be a role in surgery before symptoms develop to minimize the future risk of surgery if the tumor were to increase in size, or to ensure that endoscopic surgery is still an option. Here's an example of a patient that was told to follow up after a scan in 2018, demonstrated a large frontal sinus osteoma. Unfortunately, she was lost to follow-up and presented 3 years later with near complete obstruction of her frontal sinuses with headaches. The size of the tumor precluded any consideration for an endoscopic approach. She ultimately required an osteoplastic flap. This was another patient who was found to have an incidental finding of fibrous dysplasia causing imminent obstruction of the frontal sinus with a frontal recess outflow tract of less than 1 millimeter in size. I did elect to take this patient to the operating room before symptoms developed to ensure that no frontal sinus obstruction would occur in the future. Here's one more controversial case. This was an 80-year-old female who presented to me with a left maxillary sinus fungal ball. Imaging demonstrated a relatively large but unobstructing left frontal sinus osteoma. The debate would be to remove this frontal sinus osteoma when it is not causing symptoms. I elected to remove the osteoma under the same anesthesia to limit the need for future surgery in this elderly patient. In conclusion, fibro-osseous lesions include a wide variety of distinct entities, with the most common being osteomas, fibrous dysplasia, and ossifying fibromas. Diagnosis of these lesions is generally dependent on CT scan images, as biopsy can be challenging. Management can vary based on the pathology, and the surgical approach often depends on tumor size, location, surgeon comfort, and patient goals. Key points. Osteomas most commonly occur in the frontal sinus, with an overall prevalence of 1 to 3% per year. Osteomas grow generally at a rate of less than 1 millimeter per year, which can influence our surveillance and treatment recommendations. Treatment of fibrous dysplasia is generally reserved for cosmetic deformities, nerve compression, or pain. And while controversial in some cases, asymptomatic lesions are observed via regular CT scan for surveillance to determine growth rate and the need for future surgery. Here are my references for this presentation, and I thank you very much for your time.